And also a big thank you to Straumann for their help in bringing me here for sponsoring this session. And as you can see on this slide, this is where I come from in Western Australia, from Perth. But I don't spend all day on the beach. I'm quite busy working at the University of Sydney with students, the University of Western Australia, and also in the private practice in Perth periodontal specialists. This is my conflict of interest statement. You can see I speak for different companies, have different research grants. And again, we can't do anything without industry today. And so again, I thank Straumann for bringing this presentation to you. But I have been asked today to talk about peri-implantitis. And I'm going to address in the first hour the diagnosis, etiology, and risk factors for peri-implant diseases. And then after our break, we will talk about some of the solutions to the challenges we face. And one of the key challenges is how do we manage a patient who comes to our practice with peri-implantitis. It's a very difficult problem to manage the disease, but it's also quite challenging to manage the patient because they have certain expectations. And so I'd like to begin the presentation with a short film. And you will see that this film is showing you about a patient, her name is Claire, who is indeed rather frustrated.
Good morning, Doctor. I really didn't expect to see you so soon after you treated me just 3 years ago. And frankly, I'm pretty upset. I've had my implants for 15 years now. And for the first 12 years, everything was fine. Then I came to see you 3 years ago because I had a gum infection. I think you called it peri-implantitis, and everything changed. Back then, you even said that my implants didn't fit properly, which I really don't understand because the dentist who placed the implants actually joined the crowns together to make them stronger, and then he cemented them in really solidly. Anyways, after the extensive treatment that I had from you, cleaning around the implants and gums, adding bone material and membrane, we're now in exactly the same spot as we were before. And I find it really difficult to clean around the crowns. Why do they have to be joined together? Actually, no, I think things are even worse than they were before. And where did the infection keep coming from? So I obviously have a lot of questions that I need answered before I can make any kind of a decision about what I'm going to do. You know that I originally lost my teeth due to gum disease, but I was told that my implants would be for life. So at the top of my list is, why did no one tell me that smoking is bad for the implants? I went to go see my old dentist for regular checkups, and he never said anything. Was the work he did 15 years ago when he placed the implants bad? Was the treatment you gave me 3 years ago the right treatment? I mean, if you had a chance to do it over again, would you do the same thing, or would you do something differently? The way I see it, I can either do nothing, I could get the same treatment as I had before with the risk that I may lose my implants sometime in the future, or you could take my implants out, but then I would need to know what you're going to replace them with. I just need to know the consequences to each path. And if you're going to give me the same treatment that you gave me 3 years ago, is it going to be once and for all? I just need to know that it's going to be okay. And how much is all this going to cost me? I mean, what if I can't afford it?
So you can see Claire was very frustrated, and it's very difficult to manage a patient like this. if you have a good understanding of the problem yourself and you can communicate this to your patients, it's a lot easier to manage their expectations. So that's what I would like to bring to you, some of the key messages that you can relay to your patients, and also some of the key things you can do to prevent this disease as well as treat it. Now, we're going to look briefly at a number of studies which have investigated how patients perceive implant dentistry when they have their initial treatment, when they are diagnosed with peri-implant disease, and when they are faced with the consequences of treatment. And in this study from Spain, they actually investigated or interviewed patients and asked them, do you think you have disease or do you think your implants are healthy? Then they examined the patients and they found that the majority, nearly 90% of the patients who had a disease thought their implants were healthy. So we certainly can't rely on our patients to know that they have this disease. And only a very minor proportion of the patients actually reported symptoms like bleeding or pain. And in this study from Sweden, they also interviewed patients and they asked them questions about their initial expectations, how they felt when they were referred to the periodontist or the dentist and diagnosed with peri-implantitis, and how they felt when they had to invest again in expensive treatment. And these are some of the themes that were identified following this research. And here you can see some of the direct quotes from a patient like Claire. So initially, they thought their treatment would last a lifetime. They felt very disappointed, even feelings of shame when they had a diagnosis, and they were worried about the prognosis of their implant and also about the financial costs of treatment. And in another study, this time from America, from Michigan, they also looked at a number of patients who were in maintenance care. They gave them questionnaires and they tried to investigate how much these patients knew about peri-implantitis. And you can see that the majority of patients had no knowledge about the disease. So this is our challenge, and the solution is to make sure that we provide them with enough information actually prior to doing the implant treatment, so that if a complication does arise, they are familiar with some of the things that can go wrong. So the actual solution is education and communication. And in order for you to do that, in order for all of us to do that, we need to understand some of the key points about the diagnosis and the definitions of this disease. And I think most people will be familiar. From 2017, we had this world workshop on the classification of periodontal and peri-implant diseases and conditions. And there were 5 position papers written, one of which I wrote together with Professor Jan Lindhe from Switzerland on mucositis, and you can see there was one on health, one on peri-implantitis, and then case definitions were also presented. So I'll take you through the different definitions and case definitions of these conditions. Now, at this workshop, for the very first time, peri-implant health was characterized. And the signs are an absence of inflammation. So there should be no bleeding, no suppuration, no increase in probing depths compared to previous examinations, and also no bone loss beyond the initial bone loss that you would expect following remodeling when you place the implant. So when you look at this image, you should find it difficult to tell which is the implant and which is the tooth. The tissue should look very much like gingiva. In peri-implant health, when we look histologically, we see that we have a core of connective tissue which is covered by the epithelium. Now, this epithelium may be keratinized or non-keratinized. Then there are small clusters of inflammatory cells within the connective tissue, and around 60% of the implant is in contact with mineralized bone. So this is what the histology looks like in a healthy peri-implant soft tissues. From this very nicely written paper from Professor Jan Lindhe and Maurizio Ruggio, we see that health, again, is the absence of inflammation, visual signs of bleeding and redness, erythema, and it can exist around implants with both a normal bone level or a reduced bone support. In this paper, they said that it's not really possible to define specific ranges of probing depths compatible with health, because of course that can depend on how deeply you place the implant or not. So the key thing to look for is the absence of bleeding. If we now move to the peri-implant mucositis, this is now defined as an inflammatory condition of the peri-implant mucosa, the soft tissues, in the absence of continuing marginal bone loss. It is also considered a reversible condition. So if we treat peri-implant mucositis, we can go back to health. The cardinal sign is bleeding on gentle probing in the absence of bone loss. So we may also see other signs: deepening probing depths, suppuration or pus, edema, redness, but the key thing to look for is bleeding. And the bleeding shouldn't be one tiny little spot, but a line of bleeding or multiple spots of bleeding. And that is how we define mucositis, as you can see in this image. If we now look at the histology of the peri-implant mucositis, it is a very well-defined lesion lateral to the pocket epithelium. So in red, you see the defined lesion, which does not extend apically beyond the most apical cell of the barrier epithelium. And the infiltrate is rather rich in vascular structures, plasma cells, and in lymphocytes. If we now look at peri-implantitis, we see a different situation. Here it is defined as a plaque-associated lesion. In the soft tissues, we have inflammation, and here the key is that we have progressive loss of supporting bone, as you can clearly see in this image here. Now, if we have previous records available, so if it is a patient we have treated and we can compare the radiographs and the situation when we place the implant, we will see bleeding and or signs of suppuration, increased probing depth compared to the baseline, and progressive bone loss compared to the baseline. But of course, sometimes we have a patient who comes to us and we don't have the previous records. And then the case definition is bleeding or suppuration with deeper pockets of 6 millimeters or more, and the bone levels more than 3 millimeters apical to the most coronal portion of the intraosseous part of the implant. So you see that defined by that arrow in the radiograph. But ideally, you want to be able to diagnose early signs of disease and not wait till it gets to this stage. It's much more difficult to treat, as we will discuss. Now, if we look at the histology of peri-implantitis, and this is a view from a human histology. This is back in 2004 from Professor Berglund, and you can see the extent and the size of the infiltrated connective tissue. And it extends very close to the alveolar bone. So it is not walled off by healthy connective tissue. It is rather an aggressive lesion, you would say. And if we compare that to periodontitis on the left of the screen, peri-implantitis on the right of the screen, you can see that in the periodontitis lesion around teeth, you have this healthy connective tissue walling off the infiltrated connective tissue from the bone crest, whereas in the peri-implantitis, that does not occur. So these lesions tend to progress more rapidly, and they're more aggressive. Studies have also shown they're nearly twice as large as the periodontitis lesions, and there are a number of studies looking at human data comparing mucositis and gingivitis and periimplantitis and periodontitis. But when we think about the etiology of the disease, it's much the same as for periodontitis and gingivitis. The etiology is that it is a bacterial-induced disease. And we have many studies using different techniques, from culture analysis due to more sophisticated molecular techniques, showing us that indeed with the periimplantitis lesion, we have a lot more gram-negative microbes. We have a shift in the microbial pattern. It can be different to periodontitis, but largely we have these communities with a great abundance of gram-negative anaerobes. And there are many studies in both humans and animals looking at the etiology of biofilm accumulation and its relation to both periimplant mucositis and periimplantitis. This is a ligature-induced model in a dog. And you can see that when the plaque accumulates around the ligature, the biofilm formation occurs, there's inflammation and bone loss, often in a crater-like formed bone loss circumferentially around the implant. And if you think about the teeth, that is also very different. We often see very isolated defects on one part of the tooth, and it doesn't always circumferentially go around the tooth. So the lack of the periodontal ligament is something very important in the difference between the two diseases. Now, there's been some discussion about the role of titanium particles causing periimplantitis. You may have read this in the literature, but a very recent study from the Gothenburg group has shown when they took patients who had implants in the same mouth, some without periimplantitis and those with periimplantitis. And so it was like a split mouth situation. And they took biopsies from these patients. They did some very specific analyses to investigate the titanium particles. They also did RNA sequencing to look at gene expression profiles. And what they found, you can see in these diagrams, to the left, periimplantitis, to the right, the reference implant without periimplantitis, and both the particle location and the particle size. They actually found titanium microparticles were consistently found in these soft tissue specimens, both at implants with and without periimplantitis. So the thinking is that titanium microparticles are there and they're not associated with the occurrence of periimplantitis. So this is very new information. So if we think about etiology, we can say that it is a bacterial-initiated disease. It creates a dysbiosis between the host inflammatory response and the biofilm. And we have a reversible situation to mucositis, but once we get periimplantitis, it is much more challenging to treat. And whilst it can be treated, I would not say it is reversible. So the key differences between mucositis and periimplantitis have been in this paper, which was recently published in British Dental Journal, highlighted the differences in what you see between mucositis and periimplantitis. And one of the key things is that the onset of periimplantitis can occur very early, within the first 3 years of implant placement. And if you think about a dentition, it takes years before we see periodontitis. So this is quite rapid within the first 3 years. And it means that we have to be very vigilant and pick up early signs of disease. We also know that periimplant mucositis is a precursor to periimplantitis. So again, identifying mucositis and treating it is really important. But what happens when we have progression of disease? You can imagine we really feel very frustrated if we see images like this, where we have a patient who presents maybe in 2025 with an implant which has completely lost integration, and then we obtain previous radiographs and we see that this has actually progressed very rapidly. Maybe something could have been done at an earlier stage. Now, we also know from various studies, retrospective studies and long-term studies, that there are certain factors which influence the progression of the disease. And one such study from Berglund, published in 2018 at the bottom of this screen, was one where they found that if the implant had a moderately rough surface, that it was more at risk for progression of disease even after treatment. Now, of course, the implants we use today all have modified surfaces. So we are dealing with a problem when we get the disease, the progression can be quite fast. Let's have another look at a few other patients. This patient came to see me in 2008, and she had peri-implantitis. Despite treatment and her best efforts, it progressed quite rapidly and she lost the implant in 2009. And when we obtained previous records from the treating dentist who had placed the implant, we could see that already in 2001, between 2001 and 2005, there had been some bone loss. So here, just relying on x-rays isn't enough. You can see how quickly it's progressed. It's really important to pick signs up early using a periodontal probe. Here is another example of a patient who presented in 2007, and you can see these crater-like lesions around these implants. And obtaining previous records, you can see they were indeed placed quite well with good bone levels, but within 5 years we have this progressive bone loss. So this brings me to peri-implant probing. A very important tool is the periodontal probe, even around implants. And it is important to monitor the soft tissues to identify early signs of disease. There have been studies to show that it is quite safe to probe around an implant. The tissues will heal around in a healthy situation within 3 to 5 days. It is essential to do it at every monitoring appointment, every recall visit, and this should be done with a light probing force. So you can use a metal probe or a plastic probe. The key is to carefully assess the tissues for any signs of inflammation. This is the study from Enter in dogs that I mentioned, where they have evaluated the safety. The healing occurs within 3 to 5 days after probing, which is very similar to when we probe around a natural tooth. So the recommendations when we have placed our implant, restored our implant, are as follows. And this comes from a number of workshops and was also reiterated in the 2017 World Workshop that was held in Chicago. Use the light force, plastic or metal probe. Actually, there's been specifications for the probes as well, their diameters. Assess circumferentially at each implant. And sometimes it's not possible to probe all sites, but as many as you can. Record the probing depths. Record the presence or absence of bleeding. And record the level and width of the peri-implant keratinized mucosa. And I will come to the importance of doing that as well. The other thing that is recommended at baseline is to take a well-aligned radiograph, an intraoral radiograph, to verify the seating of the prosthesis. Does it fit well? To identify if it is cement and any excess cement. And you can see here excess cement on a radiograph. And in order to really do this, we need to align our radiographs properly, because you can see the first two radiographs, it's very difficult to see if the thing is fitting properly, or if here the excess cement, if it wasn't aligned properly, you could miss that. So using some kind of aligning device is very helpful. And this radiographic and probing measurements should be done following the placement of the prosthesis or within a few months after. And then an additional radiograph should be taken around 1 year after to see if the bone levels are stable. If the patient does present, and you've seen this slide before, with signs of disease, do your very best to obtain previous records. We spend sometimes several hours on the phone trying to get the previous records so we can make the right diagnosis. Because remember, you can have some initial bone loss which then stabilizes, or you may not have ideal bone levels right from the beginning. One thing I will reiterate is the importance of well-taken intraoral radiographs. I see a lot of patients sent to me with a panoramic view such as this, where it is very difficult to identify where the marginal bone levels are, particularly in the anterior region. And so in order to identify the marginal bone levels, intraoral radiographs are recommended. So whilst it may seem easier to take a panoramic X-ray, these types of intraoral radiographs give you much more diagnostic information. And whilst we have the possibility to take volumetric imaging, cone beam CTs, the intraoral radiograph is really the standard of care, and that's what we use to identify the marginal bone levels. Here is an example of a patient who was sent to me. Now, firstly, you can look at the panoramic radiograph, and what can you see? You can see some earrings. You can even see someone's finger, and you see the finger on the far right. Can you identify the marginal bone levels around those implants? I would say it's very challenging to do so. And so intraoral radiographs here would be much more useful. And then if you look at the prosthesis that has been made on these implants, can you imagine probing around those? Very challenging. This has been made as a horseshoe covering the implants, and it's impossible to actually probe around these implants. And in Australia, we see these patients on a routine basis where the planning and the execution of the implant placement and prosthesis design is less than adequate. So we are all responsible for making sure things can be monitored. We can't blame a patient for getting periimplantitis or poor oral hygiene if we can't monitor and they can't clean. And that's one of the key messages we need to think about, is the planning and the prevention of problems. Here is another example of contours that make it very difficult to clean and also to monitor. And so adjustments often need to be made during the treatment of the disease. Again, you can see a very nicely designed and fabricated prosthesis to the right. Here we see with the intaglio surface with a concave surface, very difficult for the patient to clean. And this is the kind of design that is ideal, where things are cleansable and easily monitored for maintenance. There have also been recent studies even looking at the contours of the single crowns, and where we have the transmucosal portion, where it is too convex. It has also been associated with signs of peri-implant disease. So we need to work together with our technicians to design and fabricate things as cleansable as possible. Another few points. Sometimes patients get over-enthusiastic with dental floss. or sometimes the prosthesis may not be smooth and the floss can get caught. And so I've seen some cases where the floss has actually been the cause of the peri-implant disease. So be aware of that. And sometimes you need to remove the reconstruction to really identify if there is anything caught down there. Another example here, you've seen this slide before of the excess cement. And we know today that we try and avoid cementation of prosthesis where possible. And if we need to cement, we do it in a way that we can easily access any excess cement. Now, I'd like to move to the prevalence of the disease. So there have been many studies looking at the epidemiology or the prevalence of the different conditions. And one of the problems was until 2017, we didn't really have clear criteria for case definition. So there's been quite a range of disease prevalence reported in the literature. And this systematic review was from 2015, but the more recent systematic reviews show the same figures. We have prevalence data of around 43% of patients, I'm not talking about implants, but patients with peri-implant mucositis, and around 22%, that's 1 in 5 people, will have peri-implantitis, which is quite high. But you can see there's a considerable range here. And of course, as we heard from Claire from the video, this treatment of this can be quite expensive, and it has now become considered as a public health issue. So it's really something that we need to focus on. And there's been a lot of discussion about the increase in prevalence, perhaps, as more and more people live longer, keep their teeth longer, but also have more implants placed. So we know that more and more people are having implants placed. They're a fantastic solution for a missing tooth. But I still think if we can maintain the teeth, that should be our preference. So I'll talk a little bit about that as well. Now, there's been some very recent data from Sweden. And there are very few countries in the world where we can obtain this data, this type of registry data, because in Australia, we don't keep a dental registry of implants placed. So it's really only in countries like Norway, Sweden, and Finland. And here in 2022, they did an investigation in their quality registry, and they found there are around 3.3 million subjects, which seems very small when you look at the population in Vietnam. But that is the number of patients they had in their registry. And the prevalence of subjects with a dental implant is around 5%, 2022. So that means around 150,000 people have at least one implant. And older people tended to have more implants. So then they looked over the 10 years previously, from 2012 to 2022. And they found that the number of implants placed had increased. It was twice as large. The increase in the proportion of people with implants had gone from around 2% to nearly 5%. And the proportion of subjects with more than 5 implants had actually decreased. So here you see more people keeping their natural teeth. And then if we think about the data from 2016 from Jan Lindhe, and we see that moderate peri-implantitis, around 15% of the population had peri-implantitis, we can think that if 5% of the population have implants, they're all at risk, and the prevalence of that will be around 15% with peri-implantitis. And that is very similar to the prevalence of periodontitis. So now we're talking about a disease, not just a complication. So for sure, if you've just started out placing implants in your career, you are going to see peri-implantitis. So it's really good to have a good protocol for management of it. And from this study from Jan Lindhe, they had looked at nearly 3,000 patient files from 800 different clinicians, general dentists, oral surgeons, periodontists, and they found that the prevalence of periodontitis, when they did this study in 2016, it was published, it was quite high. So which patients do we have to look out for? How do we manage risk, and which patients are at risk? And again, I bring you back to the workshop from 2017. And here we had a number of risk factors which were highlighted at the top. History of severe periodontitis, poor compliance with maintenance care or supportive periodontal therapy, and poor bowel control. So these are the three key risk factors. But there were also a number of risk factors, including cigarette smoking, lack of keratinized peri-implant mucosa, and diabetes, which were considered risk indicators. And today, in 2025, we have more evidence for these factors. So these are the key factors that we need to be aware of, and we should inform our patients. It doesn't mean we can't treat patients who smoke. It doesn't mean we can't treat patients who have had a history of periodontitis, but they need to be informed that they are at higher risk than people who are not in this category at developing disease. And maybe we need different recall protocols for them. Maybe we choose different types of implants for them, or different types of prostheses on the implants. So these are all of the key things. But one of the biggest risks is us as the clinician and the decisions we make on a daily basis. And I can't emphasize enough these 5 P's, as I call them, for prevention. I've been talking about these 5 P's for years, and I think they're still very relevant today. And I'm very pleased today we have more possibilities to use for our planning. So we have all of the digital technologies, the computer-assisted implant surgery, the surgical guides, different ways where we can plan things properly. We can prepare our patient by treating any periodontitis, helping them reduce their smoking or control their glycemic control if they have diabetes. We can also prepare the site augmentation. We have many different materials available today to get the best quality of bone and soft tissue before we start. And then we can place the implant in the correct manner with sufficient bone and soft tissue, design the prosthesis for cleansability, as I've discussed, and make sure they are in a supportive care program actually even before we start, even before we place the implant. So sometimes with particularly a periodontally susceptible patient, we want to make sure they have the motivation and understand how important maintenance care is before we place the implant. We even have a very recent study which was published in the journal I'm editor of from Alberto Monja, showing that if we see malpositioned implants in a patient, so too far buccal, too close to a neighboring tooth, too close to another implant, or too deeply placed, this is a risk factor for peri-implantitis. And so at a recent workshop, this was from the European Workshop on Periodontology in 2023, this scheme of prevention was presented from one of the papers. And so we have primordial prevention, prevention before we even place the implant, primary prevention, prevention of disease onset, secondary prevention, preventing disease recurrence or going from mucositis to peri-implantitis, and tertiary prevention. Prevention needs to go all the way through the life of the implant. Now, this is a good friend of mine who is a Navy diver. And you can see he has many different things on him. The camera, the tubes for the oxygen. He even has a blowtorch. He goes down and does a lot of very dangerous work. And he has a checklist to make sure every one of these things is working properly. And he has somebody else in his team who also checks off all of these things. So he's not working alone. He's working in a team, and he has a very strict checklist. And so some years ago, we developed what we call the Implant Disease Risk Assessment Tool. And this is an octagonal diagram where we have different risk factors, and I'll take you through those. And we can evaluate those risk factors for the individual patient. So it's a patient-based tool. And we can use this to identify, firstly, if they're a risk individual. And secondly, we can use this to communicate to the patient where they lie on the scale of risk and how they can reduce their risk. And we use this every day in our practice to communicate with patients, to illustrate how we can reduce the risk of disease. So if we start from the top, we see the history of periodontitis. The next vector is the percentage of sites that are bleeding on probing within the mouth. Then we have the number of pockets which are greater than 5. We have the bone loss over age, the staging and grading based on our 2017 classification. So these vectors are all related to the susceptibility to periodontitis. Then we have the regularity of them attending supportive care, the distance from the restorative margin to the bone crest at the time the implant is placed, and the characteristics of the prosthesis. Is it fitting well? Is it cleansable? How deeply is it placed? So the red part of the diagram is high risk, the yellow part is intermediate risk, and the green is low risk. And when I put all of these factors together, we have an algorithm which gives us whether the patient is at low, medium, or high risk. Now, this can be downloaded. If you have the phone, you can use the QR code. It is free access. It is also available on many different websites from the ITI, the University of Bern, and also the UK uses this frequently. And as I explained, it's fantastic for communicating with patients. And by modifying the risks, you can really educate them to continue with their regular supportive care, to make sure their level of oral hygiene is good. And this can be used also during the supportive care phase to reassess their risk. So, for example, if you have a patient who has diabetes, all of these factors and the smoking as well is all in the susceptibility vector. And you can explain that to them. Now, in terms of peri-implant supportive care, this is the protocol which has been recommended. And it's very similar to how we manage a periodontitis patient. We have firstly to interview the patient, make sure we update the medical history. Then we don't just assess the implant soft tissues. We need to look at the prosthesis. We need to assess their ability to perform oral hygiene. We then do a full mouth intraoral examination. We reinforce risk factor control. And only then do we start to clean the mouth and clean the implants. And then, of course, we need to determine, based on their risk profile, when we should see them next. Will it be 3 months, 6 months, or do they only need to come once a year? So let me show you a few examples using the hydra. Here we have a patient who is a low-risk hydra patient. You can see that here. This patient has a single implant in the 4-6 site. It's a tissue-level Straumann implant with a 1.8 collar neck, so the distance from the restorative margin to the bone is in the safe zone, you could say. The patient cleans well, has no pockets, no bleeding or probing, no history of periodontitis. They are a low-risk patient. So you might decide that you see them twice a year for their maintenance care. Here we have another patient who also has a Straumann tissue level implant, so a transmucosal implant there. But this patient has a history of periodontitis. They have been treated and they're very well maintained. They come regularly for supportive care. So they are not a high-risk patient, but they're also not a low-risk patient purely because they have this history of periodontitis. But you would assess them, and they may also only need to come twice a year for maintenance care. And now I'll show you another example, and this is a high-risk patient. This patient, you can see their full periodontal chart. They have a number of pockets with more than 5 millimeters probing depth. Bleeding out probing score is rather high. They have a poorly fabricated prosthesis on a bone level implant. They don't have peri-implantitis, but they do have periodontitis, and their risk profile is rather high. So you see, whilst the restorative margin is in the safe zone, the prosthesis is poorly fabricated, and you can see probing depths, bleeding or probing, and they never come for maintenance care. So how do we educate them? Firstly, of course, we need to treat the periodontitis, explain everything to them, remake the crown on the implant, and then we can lower their risk profile. So this is the patient after treatment with a new restoration, and they now come on a regular basis. And so we have reduced their risk from high to moderate. They will never be a low-risk patient because they have a history of periodontitis. Now, I'm going to show you one more slide, and then you can have your coffee break, because I will continue with the whole theme after the break. But I wanted to show you this slide because this is a workshop I was involved in a few years ago. It was actually during COVID, so I couldn't attend personally. I had to do everything online, but they photoshopped me in the photograph there, which was very kind of them. And this was a joint conference from the Osteology Foundation, the German Implant Association, the GGI, and SEPA, the Spanish Association of Periodontology. And they did a workshop to look at the importance of the soft tissues around implants. So at the time in 2017, we didn't know much about it, but now we have more information about the importance of having good quality keratinized peri-implant mucosa to help with prevention of peri-implantitis and peri-implant mucositis. Where we have a lack of keratinized tissue, we often see more biofilm, more plaque, inflammation. The patient has difficulty brushing, not always, but sometimes they have pain. And then if we follow things forward or we look back in time at the initial situation and we're doing a cross-sectional evaluation, we see an increased prevalence of peri-implantitis. Now, does this mean we need to graft everything? No. But when we're placing an implant, we should look at the quality of the soft tissue and consider grafting prior to implant placement. And when we see a patient like this who has difficulty cleaning and we cannot control the inflammation, then we might consider doing soft tissue grafting to improve the quality of the tissue. So I would also consider this to be one of the risk indicators. So I hope that has given you some insight into the importance of what you are doing every day, what you are doing as conscientious dentists, and planning well, placing well, maybe referring when you need to, and monitoring and diagnosing things early so that you can intervene. And after the break, I will cover the solutions to some of these challenges, and that is the treatment protocols we use for peri-implantitis management. Thank you very much.
Vâng, dừng lại đây và chúng ta có thời gian đi giải lao, sau đi giải lao.
Not treating an X-ray, we're treating a patient who has a problem. So we should always remember who is at the center of our management process. And one of the questions we should always ask is, what is it that the patient wants to achieve, and what are the questions they might ask us before we provide the treatment? So if we're presenting a treatment plan to them, if they come to us with this problem, what are some of the common questions they will ask us? And one of the first ones is, am I going to lose my implants? So we need to have an understanding of what the survival rates or the success rates of our treatment are. And we also need to understand, what does success mean for us and what does success mean for a patient? And is that the same thing? So if we look to the literature, we can see here a systematic review that was published after the 6th ITI Consensus Conference. And I know many of you are ITI members, and I would encourage you all in the room, if you're not an ITI member, to speak to the wonderful chairman and find out how you can become a member, because it's a wonderful organisation, and on a regular basis we have these consensus conferences. And this was one where one of the topics was looking at the outcomes following peri-implantitis treatment and supportive care. And we did a systematic review together with Mario Ricuzzo, Daniel Layton from Australia, and Mario's son, André Ricuzzo, who is now in China. And we looked at the time at the survival rates that can be achieved in the medium to long term, and we included only studies where they had had some type of peri-implantitis treatment. It could be reconstructive or non-reconstructive treatment, and the patients had to have been in a supportive care program for at least 3 years. So we looked at 3 years and greater, and you can see the number of studies at that time were rather few. As we got towards the 70s, only 2 studies were available. But nevertheless, the survival rates of these implants that had been treated were rather high. And you can see the ranges in 5 years between 76% to 100% of the implants were still there after 4 years. Now, that doesn't necessarily mean that the patients were happy or that the implants had no bleeding, but they were still present in the mouth. But this is the sort of information you can give to your patients when they ask you, if I go through all this treatment, will I still have my implant in 5 years? Well, you can tell them that around 3/4 of the patients to 100%, yes, still have their implant in place. So that's useful information when communicating with your patient. Now, there is a long-term study, a retrospective study, looking at outcomes from 2 to 11 years, and this was fairly recently published. And what they found was that if you have healthy tissues around a year after the treatment, that is a good predictor that you'll have long-term stability. So if you've done your peri-implantitis treatment and the patient comes back and there's still some bleeding and deeper pockets, deeper than 5, then the prognosis for that implant isn't as good. So if you have no bleeding, pockets less than or equal to 5 millimeters, as highlighted here in this table, the probability of you continuing to have stability is around 78%. So that's another thing that's good to be able to communicate with your patients. And in this table, you can see that when the implants had a modified surface, as they describe it, that means a moderately rough surface, they had less good outcomes long term than when they had a machined surface. So the older type of implants, which we still see in the patient's mouth today, tend to have a better outcome with the treatment of peri-implantitis. And this is also something that we need to think about. So the implant services vary considerably amongst different companies. And so you need to have...
Sử dụng màng á, thì mình nghĩ là nó sẽ ổn định cái xương ghép tốt hơn là không sử dụng màng. Thì có đúng không? Và cô giải thích tại sao sử dụng màng lại đau hơn.
Căng hơn. Căng. Có một cái này yếu.
Yes, the question is about you have shown some study you compare using membrane without membrane and the similar results, and the patient without membrane is less pain. So could you explain why the result is like this? Because with membrane maybe it's more stable to keep the material. Yeah, just a question.
Yeah. So we in the study we did, at the time we designed the study, there were no studies using graft with membrane versus no graft. So that's why we wanted to look at that question. For us, it made sense. If you use a graft to cover the membrane, you'll get a better outcome. The GBR studies show that a membrane gives an advantage. So if we had a defect that is not well contained and the particles might fall out, then I would recommend a membrane to try and consolidate the graft. But in the study we did, we had very well contained defects. So maybe the membrane isn't needed there. But interestingly, the other study, the Regidor one, they didn't see a difference. But to me, it makes sense. If you have only a 2 or a 3 wall defect and you want to try and contain the graft, a membrane is a good idea.
Yeah, thank you. So talking about the membrane, so most of the indication is the intra-body defect. But let's say if we have some not intra-body effect, but assume that we can clean the implant surface. So could we apply the GBR principle, like vertical geometry principle, to try to restore, to regenerate? In this world to do it?
Yes, you could do that. But could you tell your patient there is evidence showing that it will be effective? No, because there aren't any studies looking at that. So the principle of vertical ridge augmentation is to have a stable blood clot and a clean surface, a pristine implant surface to have vertical ridge augmentation. Often it's done as a stage technique where you augment the bone and then place the implant. I would not be promising my patients I could achieve a good outcome with vertical augmentation on a contaminated implant with a suprabony defect. I would prefer to remove the implant, then maybe have the vertical augmentation and consider a new implant. So I think, at least in our practice, we like to use a very evidence-based approach and not try too many things that haven't got a good sound evidence. And that's where the ITI comes in so well, don't you think? They have such good guidelines, and you're doing a fabulous job here, I hear. Congratulations.
Yeah, thank you very much. Agree. So do you have any other question? Xin hỏi với thầy cô, chúng ta có câu hỏi khác các bạn ơi. Dạ, mời anh.
Thank you. In your lecture, I saw some case with the intra-bony defects. You just open the flap and clean the implant and remove the granulation tissue, and then the bone coming back without GBR. So when we just clean and when we need the GBR, and in case we have an intra-bony defects, can we just use the membrane just like the period without any materials inside?
Yes. Well, we were also very pleasantly surprised when we saw this beautiful bone fill in these intra-bony defects just with cleaning. But because they were well contained, the blood clot was stable and it allowed the regeneration of the bone. You could also just use a membrane. Or you could, as we showed, you could put the graft and then the membrane. So you have these different options. But interestingly, the literature doesn't really show a big benefit of one over the other in these intra-bony contained defects. However, the latest systematic review shows a little bit more bone gain on the radiograph, but you have to be careful evaluating radiographs, because when you put a graft material in, are you seeing new bone or are you just seeing the graft? That is the question. So what you're saying is true. It's surprising to see that beautiful bone, but if you think about biology, perhaps it's not so surprising. You have a stable blood clot, which allows, and all the right growth factors in that blood clot to allow regeneration. But when you don't have a contained defect and the right patient and the right technique, maybe it doesn't always work like that. So you have to look at the whole thing, and you have to make sure that you have good stability if you're trying to regenerate bone, and that's where graft material and membrane may be an advantage in these less well contained defects. But it seems that for the really circumferential defects that aren't too wide, you don't need the graft.
Thank you.
Đầu tiên xin cảm ơn giáo sư có một bài rất là hay. Thì tôi thì bắt đầu điều trị quanh implant là cách đây khoảng 3 năm. Thì khi mà cô có đưa cái hình ảnh mà xử lý cái mặt mà nó viêm á, trơn láng, và tôi cũng đi học giáo sư Paulin ở cục xử lý như thế, thì tôi về tôi làm, nhưng tôi xin cô cho cách nào để mà, tại tôi sợ khi mà mình mài cái titan nó sẽ rớt vào cái mô mềm, sợ ảnh hưởng sau này. Thì tôi cũng không sure lắm, nhưng mà tôi cũng làm theo dõi khoảng 10 ca. Và cái khác biệt của cô là không có sử dụng kháng sinh. Nhưng mà tôi học ông giáo sư Pauli thì ông là sự hướng dẫn chúng tôi là phải sử dụng penicillin bôi xung quanh đó, và tôi muốn làm 10 ca nhưng mà cô vẫn theo dõi. Thì xin cô giải thích mình có thể là xử lý sao mà để cho cái hình mài mà titan nó không rớt vào cái mô mềm không, và tại sao ông giáo sư ở đây không có so sánh giữa cô và ông giáo sư, thì cái trước ý cô không có xử lý mà data, thì tôi đi học đó thì về tôi sử dụng đó, thì xin cô giải thích rõ để tôi áp dụng. Xin cảm ơn.
Tức là câu hỏi của anh đó hỏi cái cách nào làm sự sạch cái mặt implant hiệu quả, đúng không? Tức là nếu Implantology thì làm sao làm hiệu quả là điều một. Tức là và cái thứ hai là không sử dụng kháng sinh. The question is two part. First part, what is the method, the efficient method to clean the implant surface, the contaminated implant surface, because he usually use implantoplasty. And also we see some debris on implant is everywhere. So what do you think about the implantoplasty? And the second part of the question is the advantage of using antibiotic in treating periodontitis. So do you need to use antibiotic or no need to use? Yeah.
Good. Thank you for the questions. Firstly, with the implantoplasty, yes, you can use implantoplasty. The principle for implantoplasty is to create a smooth surface that is easier for the patient to clean. You should expect, are you going to translate? Yeah. You should expect, though, more recession with the implantoplasty, and it takes, it takes time. And you can have sometimes a lot of titanium discoloration in the tissues. However, the recent study I showed indicated that there is no significant benefit of using implantoplasty compared to just cleaning the surface. But you can, of course, use it. There are studies showing nice outcomes with implantoplasty. So it's not... I don't use it myself, but you can use it. That's fine to do it. And what you want to do is clean the implant surface as best you can. And we don't really know what is the best way to do it, but we think with the titanium brushes, cleaning very carefully with mechanical means, and maybe the Galvasurge will prove to be better than this, but so far we don't have good evidence for that. So all these methods are quite good. They can all be used.
And how about antibiotic?
Antibiotics. So with the antibiotics, again, you can use them, but be judicious, be very careful in your use because of the side effects and the public health issue. Because the studies don't show a significant advantage using antibiotics, yes or no. But if you have a patient with multiple implants with suppuration and very deep pockets, then I think it's also reasonable to consider using systemic antibiotics. We don't have clear guidelines when to use, and the recommendations suggest not to routinely use them.
Yeah. But actually, this question about the local antibiotic,
local
regulation, yes.
Yeah, sorry, I didn't hear it. So the local anti-delivery devices, same thing. There's not good evidence to show that they are more effective. They cost more, so it's the guidelines suggest not to use them.
Thank you. So the question for the young practitioners, usually we have to apply something, have a lot of evidence. It's good for our patient, that's ITI philosophy. But sometimes something have good evidence, not new anymore. And something new, we don't have enough evidence. And sometimes how can we face this problem when new technology coming? And we have to be cautious, or how can we face this problem nowadays?
That's a good question too. So one interesting thing that we found though from this study is that for 3 months, when the restoration margins were supramucosal or equimucosal, and this was usually when they had a tissue level implant, so the transmucosal portion allowed the restorative margin not to be placed deeply, we had a greater improvement. And there are other studies too that show if you have a deep sulcus, a deep mucosal tunnel, then it's more difficult to resolve the peri-implant mucositis. So what we do in that transmucosal area is very important. But if we come back now to non-surgical mechanical treatment, how should we perform that? And based on these studies, which you see in the blue box from the workshop, it was concluded that we recommend, so that's a strong recommendation with 2 arrows up, that we use non-surgical supra and submucosal instrumentation using curettes and or sonic ultrasonic devices. So nothing fancy. No lasers, no antibiotics, no local delivery devices, just cleaning, mechanical disruption of the biofilm, oral hygiene instruction. So you can use any of these instruments. The plastic curettes tend to be very difficult to place submucosally, but we generally would want to use instruments that don't damage the transmucosal part or the surfaces that we're cleaning, but you can actually use metal curettes. It's very similar to cleaning around teeth or the grounds around teeth, but with peri-implantitis, we also need to be aware that it's difficult to clean an implant where there's been a lot of bone loss and you have threads. So you need to think about how you're cleaning them. One thing that wasn't recommended, so we suggest not to, 1 arrow down, was lasers, purely because there is not sufficient evidence to support their benefit over and above mechanical treatment. So if you have a laser in your practice, you can still use it, but the recommendations were not that lasers were beneficial over and above their more straightforward mechanical debridement. And this was also the same for other devices, such as the airflow machine. And the reason that wasn't recommended it was because there's not sufficient evidence to show a significant advantage. And there are some case reports where patients have a problem, pain or adverse effects such as a surgical emphysema. As far as systemic antibiotics for non-surgical treatment of periimplantitis, this was also not recommended. And the main reason for that was because of the public health issue of overprescribing systemic antibiotics. And also there were no studies to show a significant benefit at the time using antibiotics with non-surgical debridement. Having said that, there has been a more recent publication by Linares where they have shown an advantage by using systemic metronidazole, but I would still caution against the regular prescription of systemic antimicrobials due to the potential for adverse effects and the limited evidence we have today for the benefits. So coming back to our flow diagram, we have the non-surgical treatment, and then when should we do the reassessment? And it was decided not to wait too long, so somewhere between 6 and 12 weeks. So we don't wait 6 months to see what's happening. And the end point that we would like to achieve is, again, this shallow pocket, so nothing more than 5 millimeters and not more than one site leading on probing. And if we can achieve that, and you see in the diagram it looks very healthy, then the patient can go into their supportive care and we can determine when we see them based on their risk profile. But if we should evaluate them at 6 to 12 weeks and find that the endpoint is not achieved, perhaps we start out with a very deep pocket and we may have had some improvement, but we still don't achieve our endpoint. So we have a pocket greater than 5, 6 or more, with bleeding at more than one site. Maybe there's still suppuration. Then we need to do something else. And of course, the patient has to agree to do that something else. So we have to explain it to them in detail, the possible adverse effects. We have to explain to them the costs. And we have to also explain to them what will happen potentially if we don't do that treatment. And if they agree to go forth with the surgical treatment, because that is what's recommended, then we have different options we can choose. We can do an access flap therapy, so we open and clean the implant surface. We can do a resective therapy, and by that I mean resect the bone around the implant. So we lower the bone and we apically position the flap. I'm not talking about cutting off the threads. I'm talking about the tissues around. Or we can try and reconstruct the defect. So we can use graft materials or biologics to try and build that bone back and possibly even reconstruct the soft tissue if we have some soft tissue loss. But irrespective of which treatment we choose to do, we need to raise a mucoperiosteal flap. So we need to have the skills to do that, remove the inflamed tissue, and importantly, decontaminate the implant surface. That's what it's all about. And then when we finish that treatment, we need to follow them up, and they also need to go into supportive care. And the recommendations were that we see them every 3 months for the first year. So here we see the recommendation 2 arrows up, these 3 approaches. And you can see in the blue box the literature, the systematic reviews which support that. You can see that the quality of evidence was moderate because we don't have really good treatment studies on periimplantitis, at least not at that time. And you can see that the strength of consensus was actually very high. None of the group abstained due to a conflict of interest. So if you had a conflict of interest, then you weren't allowed to vote. That's how strict this process was. So let's now look at a case. This is a patient who was referred to me. The patient had actually been treated by a specialist in Perth. And when they came to me, There were deep pockets. You can see the probing chart around the implant here at implant 2.5. There was an 8 millimeter mesial pocket. There was pus, bleeding, and the patient was really concerned because they'd only just had this treatment done. And when I looked carefully at the radiograph, they were sent with an OBG. We took an intraoral radiograph, and what can you see there? That things are not perhaps fitting so well. So you can see the red arrows show that there's bone loss, a poorly fitting prosthesis, and also that quantic is so close to the tissues that the patient couldn't clean under there. So there's lots of things happening there. So there's no good just doing surgery or even non-surgical therapy. The prosthesis had to come off and it had to be remade so that it fitted properly. And then we did non-surgical therapy. We left the healing abutments on or healing caps on, and we did non-surgical therapy, and then we did surgical therapy. It was a one-walled in bony defect, non-contained, so we couldn't do a reconstructive approach. And you can see here, we got the previous x-rays from the dentist. Even the impression coping wasn't correctly seated. So you can see how meticulous we have to be in every single step. And then I think we have another image here after surgery. You can see the tissues are now looking very healthy and the new prosthesis could be fabricated. This is another case where a reconstructive approach was used. Here there was a cement excess. I think I've shown you this one before. The contours of the crown weren't ideal, but the patient didn't want to go to the expense of a new crown. So a reconstructive approach was done and the patient was then satisfied. And so some of the challenges we face with the decontamination, I mentioned the different surfaces, the different roughnesses. And there have been various in vitro studies showing with using scanning electron microscopy that when we have certain surfaces, moderately rough surfaces, minimally rough surfaces, we have different patterns of bacterial contamination. And when we have these surfaces with lots of craters, the bacteria tend to go into the pores and they can be very difficult to decontaminate. So no wonder some of our techniques aren't very effective. So there's been a real concentration of effort into finding the right protocol for decontamination, and to date, there really isn't one that shows superiority over another. Here's some other images looking at the live dead staining of bacteria and the microcolonies, which tend to cover the natural surfaces of the threads, where the peaks of the threads are also covered, but the area between the threads, we tend not to get as much bacteria. And here is another in vitro study showing that the different geometry of the threads can also influence. So the threads that are abically angled or abically facing, they seem to be the most difficult ones to treat. And if you think of all the implants on the market, they all look different. So there might be different techniques that are needed to clean them, and some of them can be very challenging to treat. So in this slide, you can see two different ways of decontaminating during surgery, either with a curette and a saline. You can also use hydrogen peroxide. Here, a titanium brush. This is a Australian titanium brush which we use, and this has also been shown to be very effective in decontaminating the surface. What wasn't recommended, again, is to use air polishing or laser, again, because of the lack of evidence for the benefits of using these devices. And actually using the air polishing is off-label use because it is not sterile. So you need to think about what you're doing intrasurgically and stick to good sound principles. With regard to implantoplasty, this has been a very popular in some parts of the world technique to use a burr, a diamond or a carbide burr to remove the threads and polish the surface. Now, at the time we had these recommendations, there's insufficient evidence for any recommendation to be made. there's been a very recent study which compares implantoplasty with the titanium brush, and they had similar outcomes, but less bone loss, as you can imagine, with the titanium, using the titanium brush. So this is what we use in the clinic, the titanium brush, as well as ultrasonics, and we heavily irrigate with sterile saline. And you'll see from our studies, we have nice outcomes with these protocols. Again, if you have a laser in the clinic, you could use that, but it was not suggested not to use these devices based on these recommendations. Now, what about the solution of electrolysis or electrochemical cleaning? This has been a relatively novel procedure, although it has been around for many years. And this is now available through Straumann. They've purchased this galvasurge technique, it's called. So it's electrolysis where a controlled application of a low voltage current is used on the metallic implant in application with this electrolyte. So it's a sodium formate and salt. It's a salt buffer that is used. And this is used to remove the biofilm from the implant surface. So it is placed, the nozzle is placed into the implant. So you have to remove the prosthesis or the crown, and it cleans the implant from inside and outside. And the studies that are available, there's in vitro studies, there's also animal studies, and there are a few human studies which show nice results in terms of decontaminating the implant surface. So these images are from one of the publications from Schlee et al., where they had implants that they treated, and then they did augmentation. They submerged the implant, so they didn't place the crowns back on. They left it for a period of time, and then they did a second surgery to expose the implant and restore them. And they had some nice results at 6 months, but not all of the implants were successful. And so they were, in fact, able to remove those implants and do histology on them to see what had happened. And I'll show you some of that later. But these are two cases which have been treated in our practice. The first case is actually the one patient who had an implant. Here at the top, you can see with a poorly fabricated crown. The crown had to be replaced also. They had significant bone loss. And here you can see the galvasurge being used for the electrolysis, and the results, how clean the implant surface looks afterwards, and then the suturing. And that particular implant has now had around a year follow-up as a new crown that is doing well. And in the second case, second series, a reconstructive approach where a bone graft material was used. And again, this one is doing quite well. But the key is the whole protocol. It's not just how to decontaminate. Everything has to be done correctly. So this is an option for decontamination. It wasn't discussed in the workshop because there were no studies at the time available. So this could be a good solution for the future. Well, it's even available now. And here are the histologic views, which you can see from the 4 implants which failed in the study from Schlee and were explanted in block so that they could look at the amount of new bone that had been formed at the base of the defect. And where these red arrows are in these 4 different implants, you can see where there has been not only new bone formed, but some re-osseointegration at that previously contaminated implant surface. So probably implant 4 is the nicest one to look at. You can see the new bone in contact with the implant surface. So whilst these implants failed, they were able to demonstrate that after the use of the electrolysis, the galvasurge, they could get some re-osseointegration. And I'd like to take you back some 24 years to 2001, where Leif Persson actually showed the same thing. Re-osseointegration after cleaning of a contaminated implant surface these were Straumann SLA surfaces, and they showed good bone fill and 22% of reosseointegration when they had cleaned the surfaces when they were polished surfaces, and when they were rougher surfaces, they had 84% reosseointegration. So this is an animal model, but it's interesting. It shows you here the roughened surface, if we treat it properly, is actually an advantage to get that reosseointegration. So indeed, it is possible, even when you have a contaminated surface, if it's cleaned properly and then the flap is positioned, everything is done well, that you can get reosseointegration. So we often call this a reconstructive approach, but here you can see we can actually regenerate the bone and get reosseointegration. So I think that's really promising also. So these polished surfaces, they're not commercially available implants. That was a very, very smooth surface, comparing it to a modified, moderately rough surface. There you see the reosseointegration. So this is a study I thought I would show you. This is a multi-center recent study where they used the GalvaSurge. They used titanium brushes and hydrogen peroxide for one group. You see the titanium brush in the bottom with the hydrogen peroxide, and at the top they used the GalvaSurge and the titanium brush. Because the GalvaSurge won't remove calculus, you have to remove that first with an instrument or a titanium brush. And you can see the results there. They had good disease resolution in both groups. There was no statistically significant difference between the two groups, even though it appears the GalvaSurge had better results. The results weren't statistically significantly different. But it is an option for you to use. Now, what else does the patient ask you? They want to know if their implant will still be there, but they also want to know often when you show them the x-ray, they say, can't you put something in there? Shouldn't I have some more bone grafting? Maybe they have already had bone grafting, and now they're asking you, isn't it better to put a graft in there? And at the time of our consensus workshop, the European guidelines, there was insufficient evidence to make a statement to answer that question. There weren't enough studies evaluating. And since that date, there have been more studies, and it's very interesting to see the results. What's the other thing they want to know? Well, they nearly always ask me, is this going to be painful? They want to know, they've already been through having an implant, now they've got a problem. They want to know if what I'm going to do is going to be painful. And they also want to know, and you can guess it, they want to know how much does it cost. So they're the main things they will ask you. So let's have a look at some of the studies, and in some of the studies we'll be able to answer some of those questions, but not in all of them, because you remember I told you that very few studies report patient-reported outcomes. Now, this is a study that we did in our practice, and it was and also from other centres some years ago. And here we used an access flap therapy. We cleaned the surface with titanium brushes, curates. We did give antimicrobial systemic antibiotics, a combination of amoxicillin and metronidazole. And then the patients were seen every 3 months for follow-up. And at 12 months, we had very nice results, 100% implant survival. All of the implants had shallow pockets, mean of less than 5. They had around 1 millimeter of recession. And 47, nearly half of the implants had 0 bleeding on probing. The rest had either 0 or 1 site, and some had 2 sites. And 92% of the implants had stable marginal bone levels. So we were very happy. But we didn't ask the patients what they thought then. That wasn't something that was routinely done. And then we followed these patients up over a period of 5 years. So you can see at that time, using those success criteria, here we were very strict. We said no bleed, no pockets of more than 5 with any bleeding, no suppuration, no further bone loss, 80% success. So that's pretty good. So already back in 2018, we were using a similar endpoint to what is suggested today. Well, actually, the study was done earlier. This was the 5-year results. But now look what happened over time. And this is the key thing here is this is what you've got to warn your patients about. That whilst we may get good success at 1 year, after 3 years and 5 years, not all, but some of the patients may have recurrence of disease, and some of them may lose an implant. So you can see we lost up to follow-up. Some of them didn't come back. They might have moved, or they might have gone somewhere else because they weren't happy. We just don't know. But the majority came back. Some lost an implant, and some had recurrence of disease. And around two-thirds, 60% of the patients had that success at 5 years. So that's what I tell my patients still today. I tell them, yes, we can treat your implant, and we've got a pretty good chance of it being successful at 1 year, but we will need to make sure that we monitor it carefully because some people get recurrence and some people lose their implant. And then they make the decision then and there whether they want to try that or whether they want to have the implant out, but they're fully informed. And they're also told that they need to come regularly for maintenance care so we can pick up any problems. And the other thing we tell them is that they're likely to get some recession, because for some patients, that could be a real problem. If it's in the anterior zone and they have a high smile line, then we need to warn them of that before we do the treatment. Now, this study was done by the Swedish group, the Gothenburg group, and they here evaluated whether or not it was an advantage to use systemic antibiotics or not when they did an access flap, and here they also did some resective approach. So they actually reduced the bone levels a little. And they found some interesting things. Firstly, they found that when you had a modified surface, you had less success than when you had a turned surface. They also found that if you had the antibiotics at 1 year and you had a moderately rough surface, it was an advantage to have the antibiotics. So it helped to have the antibiotics. If you had a turned surface implant, having the antibiotics made no difference at all. And they also found that at 3 years, when they followed them up for 3 years, there was no difference in the outcome whether the patients had received the antibiotics or not. So in essence, they're saying that the antibiotics might help a bit if you have a moderately rough surface, but after 3 years, we don't really see a benefit. So again, this adds to the evidence or to the recommendation, the strength of the recommendation not to give the antibiotics. Having said that, many studies have prescribed it. Now, I mentioned about the recession, and here you can see a systematic review which summarized how much recession you get from the different approaches. So not surprisingly, if you do a resective approach, you'll get more recession because you're apically positioning the flap. If you do access surgery, the overall recession was around 1 millimeter, and with a reconstructive surgery, it was less, around 4 millimeters. So this could be an advantage of doing a reconstructive approach. And here you can see the goals of therapy, as we discussed before, and some examples of a reconstructive approach where a graft material is used, here with a membrane, and the idea here is to minimize the recession and also to reconstruct the defect. So depending on the defect configuration, we need to decide which kind of approach we will use. And this is now from the ITI treatment guideline, which I wrote together with Professor Salvi. It was published a little while ago, so many of you might have seen this. But we came up with this classification of the defects, where you might have a circumferential defect, or an interproximal defect, depending whether you have a tooth or another implant next to it, a dehiscence defect, or a circumferential suprabony defect. And then we have a table of what kind of treatment you would choose. And basically, if you have a suprabony defect with no contained defect portion, then you cannot do a reconstructive approach. There's nowhere to place the graft material. So you're really looking at either a circumferential intrabony defect or a semi-circumferential bony defect. So you have some portion that will hold the graft material. So the non-contained defects are not recommended for reconstructive approach. Now, theoretically, you might be able to use some kind of titanium reinforced membrane or scaffold and vertically augment the bone, but it's very, very challenging. And there are no studies which really show that or the efficacy of that. So this is why we recommend certain types of defects for a reconstructive approach. There was another workshop. You can see there's been a lot of workshops, but all with very clear guidelines. And this one showed the recommendations for the approach for reconstructive. So you need a flap, the decontamination of the implant surface, placement of the graft material with or without a barrier membrane, adequate flap adaptation, and again, very adequate and careful post-operative care, including chlorhexidine rinsing and then a follow-up every 3 months. Reconstructive therapy in smokers, not recommended. Doesn't mean you can't do it, but you want to have somebody who's a light smoker, not a heavy smoker. We know from the literature smoking is not only detrimental for the bone levels around implants, but also for augmentation. We've talked about the defect morphology, the contained defects, but we also think it's important to have enough keratinized tissue so that you can handle and manage the flap properly. We also need a patient who's been treated if they have periodontitis. They have really good plaque control and they're in a supportive care program. Now, what about the materials that have been documented in the literature? You can see from this slide there are many. There's different types of bone grafts, autogenous bone, even titanium granules have been used, not with great deal of success. Tricalcium phosphate, hydroxyapatite, different allografts, freeze-dried bone allograft, and deprotonized bovine bone mineral, different membranes that have been used. Non-resolvable, EBTFE, and then the collagen membranes, different types of collagen membranes, and the synthetic resorbable membranes. And also we see bioactive materials, the BMP, the PDGF, so growth factors, and the enamel matrix derivative, or the MDGAN. There are a few studies using MDGAN for treatment of periimplantitis. So there are many different approaches that can be used, and it's very difficult to decipher from the literature which is the best. In fact, it's not possible because the studies aren't there. So my recommendation is to use what has been documented and to use well-documented products so that we know that they're safe and that they're effective for augmentation, and then I think it's reasonable to use those. And for those of you attending our workshop this afternoon, we'll be looking at this reconstructive approach using some of the materials from Straumann, the collagen membranes, and the deprotonized bovine bone mineral. So this is the most widely documented material, the DBBM, for periimplantitis treatment. But another thing to tell your patients if you're going to do this treatment is that complications can occur. And when we looked at the literature in 2019 for this systematic review and this workshop, we found that sometimes you get membrane exposure reported in the studies, sometimes the bone graft particles become exposed or infected. And when a submerged protocol was used, which was in very few studies, there was often exposure of the membrane and loss of the graft particles. So these procedures are very technique sensitive and the complications can occur. And here you can see an example where membrane exposure has occurred. So let's look at some of the literature and let's also focus now on some of the patient-reported outcomes following these treatment procedures. Now, in this study, in this box here on the left, you will see the clinical outcomes. So they're the things we as dentists are keen to know. How much pocket depth reduction have we had? How much bone gain have we had? How much bleeding reduction have we had? And was there a difference between the test and the control group? So this study was looking at opening the periodontitis defect, cleaning it, closing it, no graft for the control group. And in the test group, they placed a bovine bone graft. And they also asked the patients what they thought. So they did a visual analog scale, and they asked the patients at over a period of 2 weeks and up to 2 weeks, was the surgery unpleasant? Did you have pain? And when they saw them, was there any pain today after 2 weeks? So these were the patient-reported outcomes and the clinical outcomes. So what they found in this study was that the patient-reported outcomes, there was no difference between the two groups, and the patients were all pretty comfortable. They didn't experience high levels of pain. So when the patient asks you, is this going to be paid for, you can actually say, no, the studies show that most patients don't report pain. And you can tell them that you will get quite a bit of reduction in pocket depth and bleeding. But interestingly, there was only a significant difference between the test and the control group in terms of the recession. So here, when they placed a graft, they had less recession than when they didn't place the graft. Everything else, there was no real difference. So that might surprise you that the reconstructive approach didn't result in more bone gain or more probing depth reduction in this group, but there was slightly less recession when they did a reconstructive approach. And now if we look from the same study, the reported outcomes from the patients at 12 months, you can see that, in fact, they were all very satisfied with the therapy, the two bars to the right, and they had very little unpleasant sensations in terms of pain, bad taste, pain on brushing, pain on chewing. So the patients were overall had good satisfaction, and that's also what we want. So these are some of the things you can tell your patients if you're going to do this type of treatment. Now, the next question we might ask as dentists is, if we're going to use a graft material, do we need to cover it with a membrane? And again, at the workshop, there weren't any studies evaluating this, but since then, there have been a number of studies. And the first one I'll show you is, again, a multi-center study, and this is a randomized control trial. So in one group, they used the bovine material and the membrane. In the other group, they just had the bovine material alone. Now here, it was a large study, but they didn't have always exactly the same type of defects in the two groups. So that's one thing you have to be aware of. But let's now look at two things. First, the clinical outcomes, which we would like to know as dentists, and of course, the patient-reported outcomes, which is also important. So here you can see that clinically they had good pocket reduction in both groups. They had a mean bite gain of around 1.2 millimeters in both groups, and bleeding reduction was significant in both groups. And they had a small amount of recession in both groups, but no significant difference between the group. So we see the membrane wasn't really giving an advantage in this study. What they found when they asked the patients is that the ones who had the membrane had slightly more post-surgical pain and slightly more pain at 2 weeks. But overall, they were pretty satisfied with their treatment outcomes, and they had fairly low levels of pain, slightly more when they had a membrane. Now, you've seen this slide before with respect to the keratinized tissue. And so the next study I'm going to show you is looking at 2 things they did in this treatment. Firstly, they did an implantoplasty where they removed the threads using these tungsten carbide burrs and diamond burrs, and then they polished them with an Arkansas burr to remove any of the part of the implant that was above the bone crest. And then in one group, they augmented the soft tissue using a collagen matrix, porcine collagen. And in the other group, they used an autogenous graft from the patient. So they took a full thickness flat and, they took a free gingival graft and they sutured it to the periosteum and the recipient bed. So that's what you see on the right. And then they followed these patients up for 6 and 12 months. And if we firstly look at the patient-reported outcomes, it's perhaps no surprise to you that the patients had significantly more pain when they had the autogenous graft compared to the substitute out of a packet. And they perceived the procedure to be more difficult when they had the autogenous graft. So that's not really surprising to us. But let's have a look at their clinical outcomes. At 12 months, there was no significant difference between the 2 groups in terms of the endpoint that we've been talking about. Around a third of the patients only achieved this endpoint. And in terms of the amount of keratinized tissue that was gained, there was significantly more keratinized tissue when they used the free gingival graft. So this is just another way to treat periimplantitis, where you might do a resective approach and try and increase the amount of keratinized tissue. And we see that, yes, the free gingival graft gives a little bit more tissue, but maybe the patient's wishes not to have their own palate cut might override your decision as what you would use. And here they've used implantoplasty, so that can be done. I don't do that we don't use that technique in our practice. And the recent study with the titanium brushes, which I'll show you now, confirms that that is not really an approach that gives you an advantage over other approaches. So this was only published very recently in this year in JCP, Journal of Clinical Periodontology. And here in one group, they used the titanium brush to clean the implant surfaces. And in the other group, they did the implantoplasty. And in terms of their endpoint, reaching that endpoint of shallow pockets with not more than one side bleeding, they had 26% in the control group and 40% in the test with the titanium brush. So this showed that the titanium brush is not inferior to the implantoplasty. In fact, it appears to give a slightly better result. It was more time efficient with the titanium brush and better bone preservation with the titanium brush. So whilst you can use both techniques, I think it is probably more straightforward and as effective to use the titanium brush. If we summarize the literature and we look at this systematic review, which was published in 2019, and this was from Cristiano Tomasi, they showed that there was no difference for these clinical outcomes between a flat and a reconstructive approach. And at that time, none of the studies had evaluated soft tissue levels. And today we have this more recent systematic review. This is the one that was used for the European guidelines. So you can see now there's 7 RCTs instead of 3. And now they're showing a larger improvement in bone level changes when they used the grafts, but no clear differences in the clinical outcomes in terms of bleeding and probing depth reduction between the two groups in this systematic review. So only a small percentage of cases treated achieved disease resolution. That means 0 bleeding on probing. So don't expect to have many of the patients with no bleeding. They may have one site. What you don't want is more than one site. And they say there is insufficient evidence for patient-reported outcomes and aesthetics. So interestingly, it seems even though we might measure slightly less recession, the patients mainly don't care. But be careful because you may have one patient who cares, and that can be a problem. So I'd like to show you now a study that we did in our practice, and this was after we had the results after the workshop, so this wasn't included in that systematic review. And here we had patients with specific type of defects. So they all had 3 or 4 walled intrabony defects. So we didn't have any with just one wall and certainly none with suprabony component. We were very strict on selecting the patients. They also all had very good low plaque scores and leading scores, less than 25%. And they had to have a minimum of 2 millimeters of keratinized tissue so we could handle the flap well. They weren't allowed to smoke more than 10 cigarettes a day. And they had to have implants that were placed correctly, so no malpositioned implants. And the prosthesis had to be well-fitting. So we made sure that we had at least patients with implants that had a chance of succeeding. And then we randomized to test and control. One group had the flap with no graft, and here we did a graft together with a collagen membrane. And here you can see one example of a case treated. We had a blinded examiner, so whoever did the surgery wasn't examining the patient after. You can see the protocol that was used. We had systemic antibiotics, so we used a very similar protocol to our previous study, and we followed them very carefully at 1, 4, 3, 4 weeks, and then every 3 months to 1 year. And we're continuing to follow those patients, and we're hoping soon to publish the 8-year results, so the long-term results. But let me show you what we saw at 12 months. First of all, you will see always the blue is the control group without graft. The green is with the graft and the membrane. And you can see the results are very similar, but they're also very promising results. So in these contained defects. So we have the probing depth reduction was around 4 millimeters, significant bleeding on probing. So at 12 months, nearly all of the patients had either 0 or 1 site bleeding only. And then if we have a look at the soft tissue level changes, so this is the amount of recession, we again see that the control group looks to be slightly more recession than the green group, but there was no statistically significant difference. So the mean recession with everything together around 0.5 millimeter. And then we look at the radiographic bone gain. And here you see the radiologist who evaluated. So again, that was blinded. We didn't assess it ourselves. And you see one from the control, one from the test group. These are the best cases with a very nice outcome. But overall, we had a bone gain of around 2 millimeters. So again, a very nice outcome, but no statistically significant difference between the groups. So even a very thorough cleaning, closing the flap, he can get bone regeneration here. Whether or not it's re-osteointegrated, we don't know, but we have good reconstruction of the defect. And so this now summarizes the results. You see there's no statistically significant difference in the p-value, always above the cutoff point between the two groups. And when we look at the percentage of patients who had our endpoint reached, we're around 90%. When we look at both groups, 87.5% combining the groups. So that's very positive. And now let's have a look at what the patients thought. We firstly looked to the left, the control group, the test group, and here we see the pain associated with surgery, pain during the first week, and disruption to daily activities. There is no difference here between the two groups, although we did have 30% of patients experiencing mild gastrointestinal side effects from the antibiotics. So that's another thing. If you're going to use antibiotics, you need to warn your patients that they could get side effects. Also, 2 of the patients in the test group had minor membrane exposure. Less than 1 millimeter of the membrane was exposed. And now we look at their assessment of their appearance. So their assessment of the aesthetics. And they were asked to fill out this VAS score. And you can see that the test group on the right, control group on the left, and at 12 months in both groups, they were much more happy with the appearance, probably because they didn't have red, puffy gums around their implants and no bleeding. But despite this, on average, 0.6 millimeters of recession, the patient seems satisfied with their aesthetics. But again, this is overall these 40 patients. You have to discuss individually with each patient as to whether they might be concerned about some recession. And when we ask them the last question, which I think is a really important one, if you had known you were going to get this problem and need this periodontitis treatment, would you still have chosen in the first place to have had an implant? And the overwhelming majority said yes. So despite having these problems, they were still satisfied in having implant treatment. So that was the results of our study. And we then used our criteria that we had developed. And we looked at the other studies in the literature and the criteria that they had used for success. Remember, I told you different studies use different success criteria. And we then looked at our results applying the criteria from the other studies. And you can see in these columns to the right what we found. So when we used our criteria, we had 85% success. When we used the criteria from Jepsen, which were more strict on the probing depth, we had 60%, and so on. So we found that when we compared their results, we had at least as good, if not better, results than any of the other studies using this protocol. But to finish, I would like to ask you a few questions. Where do you think the limits are? How far can we go in treating this disease? When should we make the call to remove the implant? When should we recommend either a new implant or maybe a different solution? And this is a patient I treated in 2000 and when did I treat this patient? Many years ago, more than 10 years ago. He had augmentation and then an implant placed. And in 2017, the bone levels looked pretty good around this tissue level, narrow diameter tissue level implant. And he disappeared from his supportive care program. He came back, referred back to me in 2023 with an enormous amount of bone loss, a very deep pocket, draining sinus and suppuration. And I discussed with him, I said, I think we should remove the implant and I think we should consider maybe bone augmentation, a new implant, or even considered a tooth-supported prosthesis. But he really didn't want to have the implant removed, and he said, could you please try something? I'd like to give it a try. So we did. And you can see here the enormous inflammatory lesion that is there when we raise a flap. Here there are no releasing incisions, a full mucoperiosteal flap, a very deep defect. The defect is cleaned after removing the inflamed tissue. And here we're using a very fine titanium tip ultrasonic device to clean the implant surface. You can see it's a modified surface. It's an SLA or SL active surface, and the implant is clean. You can see there really are not too many bony walls around that implant. You could maybe call it a one-wall defect on the palatal. Then a deproteinized bovine bone graft is placed to fill the defect, and a collagen membrane is placed over there, and then the flap is repositioned and sutured. Now you can see already at baseline there is a little swelling of the tissues. You can't see any of the metal collar of the implant. And here we can see the membrane in place. And now we see already 2 weeks post-operatively, yes, there has been a little bit of recession. You can see the chlorhexidine staining. 6 months, there's a little bit more recession. And at 24 months, a stable situation. Now, some patients would be unhappy with the appearance, with the recession. But you can see in his mouth, no, he's not unhappy at all. He's very happy to still have his implant placed. And you can see the bone levels, you can see the bone graft material, which is consolidated after around 24 months. We see some slight difference. And this has now been very stable for 2 years. But this patient, every time he comes in for his recall, which is still every 4 months, he is told that, yes, it's going well, but we can't guarantee this long term. We need to keep seeing you. But this is where I would book the limits. This is where I was quite happy to remove that implant. Sometimes I think when we have placed the implant ourselves, we're less likely to remove the implant. We might be prepared to try more things. But in this case, it was the patient who really wanted to do everything to try and keep that implant. And you can see he even sent me a thank you card, and he even paid the bill for his implant treatment. So we can sometimes win, even though we might think it's not a good situation. So you need to offer the patient the options, and you also need to discuss with them the alternative, and that is removal of the implant. Here is another patient which was referred to me. This is a 58-year-old male, so he's not that old. He's had all of this rather costly implant treatment done. He's clearly a periodontitis patient. He'd lost his teeth due to periodontitis, and now you see he has extensive bone loss around several implants, past deep pockets, and pretty high plaque levels, irregular supportive care, and around his lower anterior teeth, he also has 4 to 5 millimeter probing depths and severe attachment loss. So how do we manage this patient? Well, first of all, I would say a non-strategic implant with excessive bone loss. You can see he's had bone grafting in the past. We recommend to remove that and to modify the prosthesis. On the right-hand side, an attempt is made to reconstruct these defects, and the patient also requires surgery at the implant in position 1-2. So this implant is removed, the prosthesis is modified, and these implants are treated with a reconstructive approach. And here you can see the radiographic image at 12 months. And he has had pretty good response. There's a 5 millimeter pocket with one side bleeding at the 4-6 implant, and the distal implant has shallow probing depths with full absence of bleeding. This is at 12 months. And his periodontal situation is now stable. He's yet to have the upper implant base treated, because all of this has taken time, and the patient often needs to do one thing at a time. So this has all been quite costly, time-consuming, and he's been a difficult patient to manage. But he's also managed to quit smoking. That was part of the protocol. He also comes regularly now for maintenance care, and I wouldn't say his oral hygiene is good, but we support him in his maintenance by, re-instructing him every time he comes and being positive to his positive approach. So that's another difficult situation where there are multiple implants that need to be managed. So when do we remove the implants? Again, it's really a shared decision-making process. We need to take into account the severity of the lesion and the patient preference. And generally speaking, if I have had to retreat an implant that has recurrent periimplantitis, I generally won't do a second surgery. Then I'll start to discuss removal of the implant. How do we remove the implants? Well, they can usually be reverse torqued out. Sometimes we can use the reverse torque device. Sometimes that doesn't work. They might split and you have to remove them. Ideally not with a trephine, but just carefully removing the bone and fracturing them out. And they're not always easy to do. So make sure you know what anatomical structures are surrounding the implant. If it's close to the mandibular canal or the mental foramen or the sinus, you need to be careful in removing the implants. And then you need to discuss what you do next. Is it further augmentation? Do you allow it to heal and discuss then the replacement? Or do you need an immediate provisional? So there are many things to address with the patient when they're faced with this challenge of periimplantitis. So I think we're coming to the end of our time. So I'd like to summarize with you the key points, and then I'm very happy to answer any questions you may have. We started by recognizing that most patients don't realize they have this disease. So it's up to us to diagnose it, and we need to have very careful monitoring programs. And importantly, we need to establish baseline criteria so we have something to compare to as the patient progresses, and we need to see them on a regular basis. Informing them is key to avoiding their disappointment and for them to accepting our treatment protocols. But we can tell them that we can treat this disease. And I think I've shown you numerous cases where we've had very successful outcomes and happy patients. So we can tell them what I've tried to explain today, some of their success outcomes, some of the percentages they can expect, some of the problems they may expect. We know which type of defects we can choose to try a reconstructive approach and which we should stick to the access flap. And we've seen that even with an access flap therapy, you can sometimes achieve equally as successful outcomes as more complicated techniques. But in order to avoid adverse effects and complications with patient management, we need to inform them of the possible outcomes that could result in recurrence or even implant loss. So a well-informed patient is much easier to manage than a patient who has never heard of all the problems that can occur. And part of that also involves explaining to them the cost of treatment and the cost of maintenance. So make sure you don't forget that part as well. And I think the take-home message would be also that we need a personalised treatment approach. So we need to understand our patients' expectations, understand their risk factors, manage them as appropriately as possible, and design an appropriate plan to fit with the individual patient. So thank you very much for your attention. It's been a pleasure to be here. And most happy to try and answer any questions that the group may have. Sure.
Hello. Yes, thank you very much, Professor, for your impressive presentation about the implantitis. Apart from all the implantologists around the world we have to deal with. So I will ask the audience if there are any question for you. Xin hỏi quý thầy cô, chúng ta có câu hỏi nào cho cái bài trình rất là hay sáng hôm nay không ạ? Chúng tôi sẽ dịch thuật câu hỏi là. So maybe in the waiting time, I just have some question. When you do the reconstructive approach, when you go for submerged, when you go unsubmerged approach,
Yeah, that's a really good question. And generally, I do a non-submerged approach. Usually, because the patient doesn't want to go without their prosthesis. So often we have we usually take the crown off in order to do the surgical treatment because we have better access. So very rarely would leave the prosthesis on, but it's removed, especially if we want to use, for example, the galva surgery, we need to remove it to place that in there at the nozzle inside the implant. And then usually I can manage the flap and have a nice primary closure and place the prosthesis. But there are possibilities to submerge if the patient can go without their prosthesis, but sometimes it's difficult to get that good primary closure then because you can't, you might get a perforation or exposure of the membrane. So the studies don't really show an advantage of submerging. In fact, often there are more complications seen. So generally I don't submerge, but it is possible to do so. And of course, it makes sense to think that you don't then get a bacterial contamination, but it's a little bit more complex for the patient.
Okay, thank you very much. Xin hỏi có câu hỏi khác không ạ? Có ai có câu hỏi khác cho bài trình bày sáng nay của cô không ạ?
So maybe we may have another question.
So you use the Viêm material and it's well documented. But is it logical to use autogenous bond in case of you do reconstructive?
You could combine with autogenous bone, but the studies have not shown that autogenous bone is as effective. So it's nice to have that space maintaining capacity and something that has a low resorption rate. So also, you have to have a place to find the autogenous bone. But of course, you can use autogenous bone. You saw on the slide, there's a plethora of materials that have been used. But my patients usually prefer to have something out of a bottle or a packet rather than have more bone taken from their jaw. So I try to be as minimally invasive as possible. And there's not a lot of good literature on the autogenous bone. It resolves very quickly. That's a good question too. There's a question over here. Please don't be shy. I love questions.
Hỏi giùm mình đó là khi mà mình điều trị viêm quanh implant mà phẫu thuật và mình sử dụng màng thì cô nói là nó không khác biệt giữa sử dụng màng và không sử dụng màng, và nếu mình sử dụng màng thì bệnh nhân đau hơn, nhưng mà cho hỏi là cái sử dụng màng á thì mình nghĩ là nó sẽ ổn định cái xương ghép tốt hơn là không sử dụng màng, thì có đúng không? Và cô giải thích tại sao sử dụng màng lại đau hơn?
Căng hơn. Căng. Có một cái này gì đó.
Yes, the question is about you have shown some study you compare using membrane without membrane and the similar results, and the patient without membrane is less pain. So could you explain why the result is like this? Because with membrane maybe it's more stable to keep the material. Yeah, just a question.
Yeah. So we in the study we did, at the time we designed the study, there were no studies using graft with membrane versus no graft. So that's why we wanted to look at that question. For us, it made sense. If you use a graft to cover the membrane, you'll get a better outcome. The GBR studies show that a membrane gives an advantage. So if we had a defect that is not well contained and the particles might fall out, then I would recommend a membrane to try and consolidate the graft. But in the study we did, we had very well contained defects. So maybe the membrane isn't needed there. But interestingly, the other study, the Regidor one, they didn't see a difference. But to me, it makes sense. If you have only a 2 or a 3 wall defect and you want to try and contain the graft, a membrane is a good idea.
Yeah, thank you. So talking about the membrane, so most of the indication is the intra-body defect. But let's say if we have some not intra-body effect, but assume that we can clean the implant surface. So could we apply the GBR principle, like vertical geometry principle, to try to restore, to regenerate? In this world to do it?
Yes, you could do that. But could you tell your patient there is evidence showing that it will be effective? No, because there aren't any studies looking at that. So the principle of vertical ridge augmentation is to have a stable blood clot and a clean surface, a pristine implant surface to have vertical ridge augmentation. Often it's done as a stage technique where you augment the bone and then place the implant. I would not be promising my patients I could achieve a good outcome with vertical augmentation on a contaminated implant with a suprabony defect. I would prefer to remove the implant, then maybe have the vertical augmentation and consider a new implant. So I think, at least in our practice, we like to use a very evidence-based approach and not try too many things that haven't got a good sound evidence. And that's where the ITI comes in so well, don't you think? They have such good guidelines, and you're doing a fabulous job here, I hear. Congratulations.
Yeah, thank you very much. Agree. So do you have any other question? Xin hỏi quý thầy cô, chúng ta có câu hỏi khác các bạn ơi. Dạ, mời anh.
Thank you. In your lecture, I saw some case with the intra-bony defects. You just open the flap and clean the implant and remove the granulation tissue, and then the bone coming back without GBR. So when we just clean and when we need the GBR, and in case we have intra-bony defects, can we just use the membrane just like the period without any materials inside?
Yes. Well, we were also very pleasantly surprised when we saw this beautiful bone fill in these intra-bony defects just with cleaning. But because they were well contained, the blood clot was stable and it allowed the regeneration of the bone. You could also just use a membrane. Or you could, as we showed, you could put the graft and then the membrane. So you have these different options. But interestingly, the literature doesn't really show a big benefit of one over the other in these intra-bony contained defects. However, the latest systematic review shows a little bit more bone gain on the radiograph, but you have to be careful evaluating radiographs, because when you put a graft material in, are you seeing new bone or are you just seeing the graft? That is the question. So what you're saying is true. It's surprising to see that beautiful bone, but if you think about biology, perhaps it's not so surprising. You have a stable blood clot, which allows, and all the right growth factors in that blood clot to allow regeneration. But when you don't have a contained defect and the right patient and the right technique, maybe it doesn't always work like that. So you have to look at the whole thing, and you have to make sure that you have good stability if you're trying to regenerate bone, and that's where graft material and membrane may be an advantage in these less well contained defects. But it seems that for the really circumferential defects that aren't too wide, you don't need the graft.
Thank you.
Đầu tiên xin cảm ơn giáo sư có một bài rất là hay. Thì tôi thì bắt đầu điều trị quanh implant là cách đây khoảng 3 năm. Thì khi mà cô có đưa cái hình ảnh mà xử lý cái mặt mà nó viêm á, trơn láng, và tôi cũng đi học giáo sư Paulin ở cục xử lý như thế, thì tôi về tôi làm, nhưng tôi xin cô cho cách nào để mà, tại tôi sợ khi mà mình mài cái titan nó sẽ rớt vào cái mô mềm, sợ ảnh hưởng sau này. Thì tôi cũng không sure lắm, nhưng mà tôi cũng làm theo dõi khoảng 10 ca. Và cái khác biệt của cô là không có sử dụng kháng sinh. Nhưng mà tôi học ông giáo sư Pauli thì ông là sự hướng dẫn chúng tôi là phải sử dụng tetracycline bôi xung quanh đó, và tôi muốn làm 10 ca nhưng mà cô vẫn theo dõi. Thì xin cô giải thích mình có thể là xử lý sao mà để cho cái hình mài mà titan nó không rớt vào cái mô mềm không, và tại sao ông giáo sư ở đây không có so sánh giữa cô và ông giáo sư, thì cái trước ý cô không có xử lý mà tetra, thì tôi đi học đó thì về tôi sử dụng đó, thì xin cô giải thích rõ để tôi áp dụng. Xin cảm ơn.
Tức là câu hỏi của anh đó hỏi cái cách nào làm sự sạch cái mặt implant hiệu quả, đúng không? Tức là cái Implantology thì làm sao làm hiệu quả là điều một. Tức là và cái thứ hai là không sử dụng kháng sinh. Vì sao không dùng kháng sinh? The question is two part. First part, what is the method, the efficient method to clean the implant surface, the contaminated implant surface, because he usually use implantoplasty. And also we see some debris. The implant is everywhere. So what do you think about the implantoplasty? And the second part of the question is the advantage of using antibiotic in treating periodontitis. So do you need to use antibiotic or no need to use? Yeah.
Good. Thank you for the questions. Firstly, with the implantoplasty, yes, you can use implantoplasty. The principle for implantoplasty is to create a smooth surface that is easier for the patient to clean. You should expect, are you going to translate? Yeah. You should expect, though, more recession with the implantoplasty, and it takes, it takes time. And you can have sometimes a lot of titanium discoloration in the tissues. However, the recent study I showed indicated that there is no significant benefit of using implantoplasty compared to just cleaning the surface. But you can, of course, use it. There are studies showing nice outcomes with implantoplasty. So it's not... I don't use it myself, but you can use it. That's fine to do it. And what you want to do is clean the implant surface as best you can. And we don't really know what is the best way to do it, but we think with the titanium brushes, cleaning very carefully with mechanical means, and maybe the Galvasurge will prove to be better than this, but so far we don't have good evidence for that. So all these methods are quite good. They can all be used.
And how about antibiotic?
Antibiotics. So with the antibiotics, again, you can use them, but be judicious, be very careful in your use because of the side effects and the public health issue. Because the studies don't show a significant advantage using antibiotics, yes or no. But if you have a patient with multiple implants with suppuration and very deep pockets, then I think it's also reasonable to consider using systemic antibiotics. We don't have clear guidelines when to use, and the recommendations suggest not to routinely use them.
Yeah. But actually, this question about the local antibiotic regulation, yes.
Yeah, sorry, I didn't hear it. So the local anti-delivery devices, same thing. There's not good evidence to show that they are more effective. They cost more, so it's the guidelines to suggest not to use them.
Thank you. So the question for the young practitioners, usually we have to apply something, have a lot of evidence. It's good for our patient, that's the ITI philosophy. But sometimes something have good evidence, not new anymore. And something new, we don't have enough evidence. And sometimes how can we face this problem when new technology coming? And we have to be cautious, or how can we face this problem nowadays?
That's a good question too. So I think we have to be open to new technologies, new things. But myself, I always think, what would I like to have for my own mouth? Would I like to have someone try something new that is not proven? No. So I like to see that there are safety studies and that there is some level. I don't need 15 randomized controlled trials, but I do need some evidence. So I always think it's important not to just try everything that a different rep from the day comes and gives you. Make sure you know what's in it and you make your own decision in conjunction with the patient. And if it's something relatively new and your patient agrees, and then of course you can try it, but make sure they understand that there's not a lot of evidence behind it. Just be honest and transparent.
Yes, thank you very much. Xin hỏi còn câu hỏi nào khác với câu buổi sáng hôm nay không ạ? Yeah. Okay, so no more questions. So on behalf of the organizing committee, would like to thank you very much. Xin mời thầy phó sư Trần Cẩm Bính lên trao quà lưu niệm.